Let's discuss the new video of clinical snippets on a neurological case with an interesting finding of bilateral hand wasting. Bilateral hand wasting is a condition in which there is a progressive loss of bilateral muscle mass in both hands, and in this we see that the patient loses the fine motor skills and the gripping qualities of the muscle. Let's discuss the causes of it and the clinical scenario in which we'll inspect and palpate the findings of the patient. On clinical examination, we can see the flattening of thenar and the hypothenar muscles and the flattening of the hands. And on the same other side of the hand, we can see the same. The flattening of the hand is same. On palpation, we can confirm the thinning of both the muscles, thenar and the hypothenar. Here we can see the wasting of intraosseous muscles. Let's now check for the grip strength. It is 40% in this arm and compared 50% in this arm. Let's discuss the causes of bilateral hand wasting, neurological cause and systemic causes. In neurological causes, we have leprosy, bilateral ulnar nerve palsy, amyotrophic lateral sclerosis, spinal muscular atrophy, cervical myopathy, Syringomyelia, Charcot-Marie-Tooth disorder, which is a variant of hereditary sensory motor neuropathy, chronic light exposure, peripheral neuropathies, brachial plexopathy, Hirayama disease, which is a progressive idiopathic wasting of muscles of hand and forearm, myopathies distal prominently, dystonia myotonica, and in non-neurological causes we have rheumatoid arthritis and chronic wasting syndrome, in which HIV and TB.
So now coming to, we already know the differential diagnosis. The list seems long, but some of these things are rare. And what I will do is, what are the other associated bedside findings in a case of a patient presenting to you with bilateral hand wasting? In neurological examination, when we go ahead, what are the cumulative other positive signs that will make us aware that what are the conditions I am dealing with, or what are the differential diagnosis can be ruled out? That is the other bedside associations of clinical examination in a neurological case with a predominant bilateral hand wasting. So if it is a leprosy, what are the cardinal things I will look for in the general examination here is thickened nerve. So in a case of peripheral neuropathy, or when a case is presenting with bilateral hand wasting, look at it. Is it clawing? Is it overt clawing? That is the hyperextension of the metacarpophalangeal joint and flexion of the interphalangeal joint, suggesting the weakness of the introsei and lumbrical muscles. So what is happening is, I will palpate the thickened nerve. If present, thickened plus minus tender, I am going towards leprosy. Leprosy patients may also be associated with peripheral neuropathy. So I will also look for the sensory examination in the lower limbs. Okay, so thickened tender nerve, bedside, hand wasting. Amyotrophic lateral sclerosis, as you know, it is a variant of motor neuron disease. Motor neuron disease is a classical neurological condition which only attacks pyramidal tract, anterior horn cell, or the bulbar muscles by involving the cranial nerve nuclei, or the pseudobulbar part, that is the corticobulbar fibers along with cortex. So these are varied presentations of motor neuron disease, and amyotrophic lateral sclerosis is a situation in motor neuron disease where there is degeneration of the two things, pyramidal tract and the anterior horn cells. So the hand wasting, what you will be seeing, is due to anterior horn cell involvement in a case of amyotrophic lateral sclerosis. That hand wasting will be there, and sometimes a very specific type of hand wasting occurs in amyotrophic lateral sclerosis. Only the thenar eminence is wasted, sparing the hypothenar eminence. This can be a differential diagnosis of mononeuropathy due to a carpal tunnel syndrome or a median nerve compression here. But along with larger distribution of clinical findings, what I will tell here now, and selective sparing of the hypothenar muscles, that is known as thenar index, or only the thenar muscles are targetedly involved. Sometimes it's a signature sign of amyotrophic lateral sclerosis, and in this patient, along with the muscle wasting in the hand, when I go for the reflex, I will see that there are wasting of the forearm muscles, wasting of the deltoid muscle, arm muscles, But when I am examining the reflex, in that hypotonic vested hand, the reflexes may be exaggerated. So there is a plus minus combination of upper motor neuron and lower motor neuron sign in one limb only. A vested limb without power, but the reflex is exaggerated. I will think of amyotrophic lateral sclerosis. I will look also for the other cranial nerve examinations, fasciculations of the tongue, fasciculations over the other muscles. Then this can be amyotrophic lateral sclerosis. Spinal muscular atrophy is also a variant of motor neuron disease where only the anterior horn cells are involved. Only the anterior horn cells are involved. So there will be long segment myelopathy. There will be long segment, the muscular atrophies involving the muscles of the arm, forearm, and the hand. And definitive investigations like nerve conduction study, EMG will give me the result. Here also the nerve conduction study and all associated clinical signs what we have seen. Cervical myelopathy, this is another combination where I will get upper motor and lower motor neuron signs. So hand wasting. Upper motor neuron signs present in the lower limbs. Lower motor neuron signs present in the upper limbs. You always think of cervical myelopathy. Ask about radicular pain. Patient will present with quadriparesis. Ask about radicular pain, neck pain. Palpate the cervical spinous processes, any tenderness. You will get lower motor neuron signs, matlab you are seeing the wasting of the hand muscles. But as you go down, you will see that other reflexes are exaggerated, like knee is exaggerated, ankle is exaggerated, plantars are extensor. And at the level you are getting the lower motor neuron signs. So here, in a case of cervical cord compression, if it is extradural cord compression, radiculopathy, neck pain, all these things are localizing signs. So this, if there is a hand muscle weakness, maybe CAP1, something is a localizing sign in cervical spine, if there is quadriparesis. So in MRI of the cervical spine, I will investigate. The MRI of a cervical spine will give me the diagnosis. Here also, in all cases of amyotrophic lateral sclerosis, always go for an MRI of cervical spine, because without ruling out cervical myelopathy, never level amyotrophic lateral sclerosis. So here MRI will help me. Other clinical clues I will tell you. And there is a sensory loss. Obviously, there will be loss of sensation, involvement of the bladder, irrespective, contrary to amyotrophic lateral sclerosis, spinal muscular atrophy, where bladder is not involved, no sensory involvement. Here there will be loss of sensation below a level and other things whatever. Syringomyelia is intermedullary cord compression. So the classical presentation will be quadriparesis, small muscle hand wasting. Whenever you see small muscle hand wasting, you go for a sensory examination test, especially in the hanging distribution of the chest. This part you should examine the sensory examination. Deltoid, this part of the chest. There can be patchy sensory distribution here in a hanging manner. So this hanging anesthesia will give us clue towards intramedullary cord compression, expanding lesion, that is the Syringomyelia. Okay, there will be dissociate anesthesia, loss of spinothalamic sensations, and there will be preservation of position vibration sensation. There will be sacral sparing, quadriparesis, and Syringomyelia with. So these are the associated findings. I will label the case of intermedullary cord compression, Syringomyelia. Again, I will go for a cervical spine MRI where I can see the syrinx. Okay, Charcot-Marie tooth disease is a hereditary sensory motor neuropathy. The hereditary sensory motor neuropathy with hand wasting. In the lower limb examination for Charcot-Marie tooth disease, what I will see is there is a pes cavus deformity. High arched foot, pes cavus, there can be kyphoscoliosis associated, and there will be wasting of the leg muscles disproportionate to the wasting of the thigh muscle. So the legs appear like a champagne glass appearance. Extreme thinning of the lower leg part and the pes cavus deformity, hallus valgus, pes cavus. Extreme thinning of the leg, preserved thigh muscles, little bit affection of thigh muscles. So champagne glass appearance, sensory loss, Charcot-Marie tooth disease, very hallmark clinical associations. Nerve conduction study will give me the diagnosis. Neuropathic, chronic lead exposure, ask history of working in any factory or lead exposure, will take history of lead exposure, and usually it is a very rare thing. Lead exposure can present as unilateral hand wasting, Bilateral is very rare, but still cases of bilateral hand wasting present. We ask the history, there is a chronic lead exposure. Peripheral neuropathy, very easy. The history won't start from here, the history will always start from the lower limbs. Tingling, burning, whatever positive or negative phenomena gradually ascending from the lower limbs. When it ascends up, sensory symptoms will be the predominant first clinical history. They ascend up, then tingling start in the fingers. By the time the tingling reaches the knee, peripheral neuropathy. And there are certain situations where muscle atrophy and wasting is very characteristic in certain peripheral neuropathies. So a nerve conduction study and a classical history of this pattern of polyneuropathy will give me hint that I am dealing with a case of peripheral neuropathy. ENG, NCV, axonal degeneration or segmental demyelination, this investigation should be done, and causes of peripheral neuropathy is long. We should rule out peripheral neuropathy. Brachial plexopathies present with bilateral hand wasting, especially the lower trunk of brachial plexus C8T1, especially C8T1 brachial plexopathy due to injury, avulsion, Klump's paralysis, birth injuries or whatever. Especially do not forget about a Pankos tumor when it compresses the C8T1. The smoker, recent onset gradually progressive hand muscle weakness. Look at the Horner syndrome in the eye Horner syndrome. MRI cervical spine, MRI HRCT thorax. Am I missing a Pankos tumor? So this is important here. Brachial plexopathy and history of other cord avulsions, cord injury in adults, whatever. Hirayama disease will be diagnosis of exclusion. It is also known as monomelic amyotrophic. It will be diagnosis of exclusion. Here is a idiopathic disease which is gradually progressive and is causing wasting of the forearm and hand muscles. All these investigations should first be done before leveling this. Distal myopathies, okay, the hands are looking like wasted, but actually I am dealing with myopathies. There are very rare variant, genetic variants. So here EMG will give me the answer. EMG will give me the answer that probably this is not a nerve conduction slowing, it is polyspikes. That is a myopathy, and maybe I am dealing with a rare myopathy which is distal predominant. As you know, myopathies are always proximal predominant. Here is a distal predominant myopathy. Genetic testing I will do. No need to go to the details of this. Genetic testing. Just know that myopathy should have been presented like this, proximal weakness. But here is a case of presentation with distal predominant myopathy with wasting. I am going for an EMG MCV, and EMG is telling me that it is not a nerve conduction delay, it is a muscular problem. So I will deal with those things. Dystrophia myotonica is a classic presentation in the adults. It's a very classic myopathy in the adult, dystrophia myotonica, but there will be a classical facies which is known as myotonic facies. The forehead is broad, the hairline is receded. There is a typical myopathic facies, small eyes, and there is a compensatory. The patient is compensatory looking up, is trying to tighten these muscles, frontal belly of occipitalis muscle. He is overtly using it when asked to look up. So this classical myopathic facies, and associated with there is tonic delayed relaxation of the reflexes. Mind it. There is another endocrine condition, that is hypothyroidism, which causes delayed relaxation of the reflexes. In dystrophia myotonica, you will also get delayed relaxation of the reflexes, and the very classical test they do, how to demonstrate myotonia, dystrophia myotonica. So myotonia, in the particular, in the hammer, pick up the hammer and strike on the thenar eminence. You will see the thenar eminence muscles contracting and relaxing very slowly. That is how you demonstrate bedside myotonia. There will be diabetes, gynecomastia, associated conditions, cataracts. Again, the EMG will give me the answer that it is a myopathy, borderline elevation of creatinine, phosphokinase. So all these bedside clinical findings, I will suspect myotonia. Eyes appearing ptosis, the myotonic facies I know. Now I describe whatever it is. So dystrophia myotonica. Rheumatoid arthritis, cachexic syndromes. Rheumatoid arthritis, again, the inflammatory condition, gradually progressive inflammation. Actually, it is a musculoskeletal, it is a axial, it's a disorder that is involving the skeleton, that is the peripheral skeleton, and it's an inflammatory disease. So it's an inflammatory disease, there are associated with hand deformities. So the classical rheumatoid arthritis hand deformities only will tell me that this is an inflammatory cachexia of the hand wasted, and because of disuse, non-use, severe arthropathic limbs, deformities, just jet deformity, swan neck deformity, all these deformities is making me that this wasting is non-neurological. Likewise, cachexic disorders like chronic tuberculosis, HIV, it's an inflammatory cachexia, and that is a muscle wasting predominantly involving all the muscles. So when you are seeing there is hand muscle weakness, there will be generalized cachexia and a systemic disease affecting it. So this is how, in a nutshell, bedside examination, what can give us clues to various conditions that lead to wasting of the both hands. So it is not just the examination of this, it's the examination of the whole body starting from history, taking cues, examining the small muscles of the hand, which is out of discussion of this snippet. We have already dealt with how to examine small muscles of the hand. You can go and visit. So examination small muscle of the hand, detailed neurological examination, reflexes that will tell us other various cues what I am dealing with, and ultimately it will be nerve conduction studies, electromyography, somewhat thick and tender. Now I have told you nerve biopsy will help us like delineate the cause of peripheral neuropathy very rarely, like vasculotic neuropathies and leprosy. So nerve biopsy is also required, amyloidosis, sarcoidosis. So the different things are there. And MRI, never forget MRI, cervical spine, most important disorders, common disorders and important disorders. Say for example, your cervical myopathy, most common cervical myopathy, amyotrophic lateral sclerosis should be ruled out. It should be never the first diagnosis. Rule out cervical myopathy in this scenario. Syringomyelia, cervical myopathy, brachial plexus injury, MRI. So all these things will give me the result what I am thinking of this differential diagnosis. Treatment is treatment of the cause, physiotherapy. Rarely acute situations, if there is some trauma, avulsion and all those things, then tendon transfer, surgical intervention may be helpful, but usually what we are dealing with neurological conditions, they are already late by the time wasting is happening. We have to just delay the progression and try to achieve the diagnosis, physiotherapy and other things. Thank you.